Welcome. The following presentation is from a satellite symposium presented by Answers and CME, held prior to the 2026 American College of Physicians Internal Medicine meeting, titled Advancing Cardio-Kidney-Metabolic Care in Internal Medicine, Evidence-Based Guidance for Incorporating Nonsteroidal MRAs. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated.
Good evening, everyone. Thanks so much for joining us this evening. Welcome to Advancing Cardio-Kidney-Metabolic Care in Internal Medicine, Evidence-Based Guidance for Incorporating Nonsteroidal Mineralocorticoid Receptor Antagonists. My name is Nosheen Riza. I'm an assistant professor in advanced heart failure, transplant, and genetic cardiologist at the University of Pennsylvania.
And my name is Muthu Vadaganathan. I'm a general cardiologist at Brigham and Women's Hospital and Harvard Medical School.
And we're very excited to be here with you this evening talking about this topic. Here are our disclosures briefly. And our educational objectives. So during our evening together, we hope to have you be able to specify the rationale for nonsteroidal mineralocorticoid receptor antagonists, or NSMRAs, as you'll see throughout our presentation, for treatment of adult patients with heart failure, with or without chronic kidney disease or type 2 diabetes. We'll also talk about the risk-benefit profiles of these medications and the current standard of care for patients with heart failure with mildly reduced ejection fraction or heart failure with preserved ejection fraction. And then we'll talk about patient-centered long-term care strategies to make sure that we succeed in treating our patients with these multiple chronic comorbid conditions. This activity is sponsored and supported by an educational grant from Bayer Healthcare Pharmaceuticals, and Answers in CME is providing the accreditation for this event. You can get CME credit for your participation in the event by scanning the QR code that's come up a couple of times already. We're going to show it again on the next slide. So if you're here in person, scan the QR code on your mobile device to earn credit for your attendance. And for those of you joining us online and streaming after the program, you can click the button to get your credit. And for those of you who haven't had the chance to scan that QR code, here it is. We'll give you a couple of seconds. We're also going to be taking your questions. We'll get them right up here on the Q&A tablet, and we'll be answering them throughout the session. So we're really looking forward to engaging with you all in that way as well. And again, for those of you streaming, questions will automatically appear on your screen, and everyone is able to ask a question using the online tab. All right. With all that housekeeping out of the way, let's go ahead and get started. First, we'll talk about the rationale for nonsteroidal MRAs, addressing this unmet need. So as cardiologists, obviously internists, and other clinicians here in the room, we're all used to taking care of patients with these conditions: hypertension, dyslipidemia, metabolic syndrome, diabetes, chronic kidney disease, cardiovascular disease. And typically, we have all been in our little silos treating these conditions in isolation. We have disease guidelines to manage coronary artery disease. You have disease guidelines to manage high blood pressure. Endocrinologists have guidelines to manage diabetes. The nephrologists have kidney guidelines. So we're all kind of doing the same thing, but separate. What we're starting to realize is that it doesn't make sense to do medicine that way anymore. When you first talk about the pathophysiology, as we're talking about here, there is a lot of overlap in how these cardio-kidney-metabolic interactions happen. Many of these conditions are driven by inflammation, oxidative stress, insulin resistance, and vascular dysfunction, bringing this, again, all together in the comorbidities that we see in our patients every day. So increasingly, this concept of this overlap, not only on the pathophysiological level, but also, again, on the clinical level, is coming to surface. And in 2023, the American Heart Association put forward this new standard called Cardio-Kidney-Metabolic Syndrome, or CKM syndrome. What this outlined is really, again, the integration and realization that all of these conditions are driven by common risk factors, and that potentially, as we'll talk about throughout our time together, their treatments may overlap as well. So what we call somebody with CKM stage 0 here, for example, is somebody who does not have any of these risk factors just yet, and it's an opportunity for prevention. For CKM stage 1, that's an individual with excess dysfunctional adipose tissue, again, driving that process of insulin resistance, inflammation, really starting this cascade. That's somebody who's overweight or obese, has abdominal obesity or impaired glucose tolerance. And then as you can see, as you proceed through the CKM stages, you accumulate more and more of these cardiometabolic risk factors, including hypertension, metabolic syndrome, chronic kidney disease, hypertriglyceridemia, type 2 diabetes, that progresses and manifests in subclinical atherosclerotic cardiovascular disease, subclinical heart failure, and then stage 5 is clinical CVD, meaning heart failure, coronary heart disease, PAD, stroke, and AFib. So why does this distinction matter? Well, we know that actually the higher you are in the CKM staging, or the more of these chronic comorbidities, risk conditions you have, the worse your mortality. So you can see here on this graph over time, progression throughout 15 years and accumulated incidence of cardiovascular mortality. Again, those who have manifested clinical cardiovascular disease and CKM syndrome with excess mortality, but still a high rate of mortality for even those with just CKM stage 1. So again, an important opportunity to realize that we have for intervention. Now moving to heart failure, we and you are probably used to thinking about heart failure on this spectrum of ejection fraction, using that number to identify what kind of heart failure somebody may have. You're very familiar with the concept of heart failure with reduced ejection fraction and the 4 pillars of treatment for HFrEF, tried and true. We're all used to that. The part of heart failure that has evolved a lot in the last 5 to 10 years is the concepts of this heart failure with mildly reduced or heart failure with preserved ejection fraction. You can see that here, heart failure with these types, similar mortality to heart failure with reduced ejection fraction, 5-year mortality up to 75%, still a highly lethal condition. And also considerable morbidity. Over 50% of these individuals have more than 5 significant comorbid conditions, some of which we've already talked about. And historically, there have been very limited targeted therapeutic options for these groups of patients. Again, you're familiar with the beta blockers and renin-angiotensin inhibitors and SGLT2 inhibitors and MRAs for HFrEF, but what do we actually have for HFpEF? Well, for a long time, it was really nothing. But in the last 5 years or so, we're setting a new standard for heart failure with preserved ejection fraction, again, the foundation of how we get to that condition of this cardio-kidney-metabolic syndrome. So we're mirroring what we've done in HFrEF here with 4 pillars of CKM syndrome treatment that we'll talk about today. RAS inhibitors are still a mainstay, SGLT2 inhibitors as well. We'll talk a little bit about GLP-1 receptor agonists and, of course, nonsteroidal MRAs. Again, creating this foundational approach for the treatment of heart failure with preserved ejection fraction, on top of lifestyle modification and things we've discussed in that earlier CKM staging, blood pressure management, blood sugar management, lipid management, and lifestyle modifications. So these 4 pillars, again, address different aspects of the drivers of CKM syndrome and the drivers of HFpEF, all the way from hemodynamic perturbations, metabolic dysregulation, and the inflammation that we talked about earlier. And what we know is even though these 4 pillars attack different axes of this pathophysiology, cumulatively they provide synergistic benefits when combined with traditional foundational management strategies. And we'll zoom in on the concept of mineralocorticoid receptor antagonism in the treatment of heart failure. Again, you're familiar with MRAs in the treatment of HFrEF, but again, we're learning more about this concept in the treatment of other types of heart failure as well. You remember that heart failure exacerbates the renin-angiotensin-aldosterone system, really ramping it up, driving the adverse cardiac remodeling that you see here: hypertrophy, fibrosis, inflammation, endothelial dysfunction, apoptosis. And what MRAs do is really inhibit those pathways that promote this adverse cardiac remodeling. So we'll have our first knowledge check-in now. So what is the primary mechanism by which steroidal and nonsteroidal MRAs exert their therapeutic benefit in heart failure? I'll let you read the answer choices there. And our in-person audience, again, you can scan the QR code to answer. All right, 68% of you hopefully heard what I said on the immediate preceding slide, got that correct. So yes, the primary mechanism is by inhibiting pathways that promote adverse cardiac remodeling. And then again, just a reminder, we already have some amazing questions already submitted to us, so keep them coming. And I'll pass it over to Dr. Vaduganathan to take it from here.
Fantastic, and we'll be addressing those questions predominantly at the end of the session, so please continue to enter those. They're really, really important questions, and I think some of the information we'll be presenting will provide some context to those questions as well. So in the last 5 years, we've had this remarkable revolution in care for these major conditions, especially chronic kidney disease and heart failure with preserved ejection fraction. And so in essentially a very, very short period of time, we've gone from a period in which we didn't have established therapies to now with more than 5 therapies approved for use for the management of heart failure with preserved ejection fraction today. So that's a pretty remarkable change. And so I hope to take you through some of the evidence for where we've come in these few short years. I'd like to begin with the nonsteroidal MRAs, and in particular, there's one drug in the class, finerenone, that has been finally established in heart failure with preserved ejection fraction. This was shown in the Fine Arts HF trial. This was a large-scale trial of about 6,000 people with heart failure with mildly reduced, and that's that EF range between 40 and 50%, and truly preserved ejection fraction, an EF above 50%. And this nonsteroidal MRA was compared against placebo, and patients were followed over time for 2 to 3 years, and there was a clinically relevant 16% reduction in the primary endpoint. And importantly, the benefits were observed even in patients who were already being treated with other classic cardio-kidney-metabolic medications like an SGLT2 inhibitor. In fact, SGLT2 inhibitors, which I'll review, were the first foundational class for heart failure with preserved ejection fraction. And so it's reassuring to see that the benefits of adding a nonsteroidal MRA are even observed in people already treated with an SGLT2 inhibitor. Importantly, the nonsteroidal MRA, finerenone, has been studied in both heart and kidney disease. Its initial approval in the US was based on 2 large-scale chronic kidney disease trials that established its efficacy and safety in individuals with diabetic kidney disease. And so this 3rd trial in heart failure now brings together this cardio-kidney-metabolic triangle. And here you can see that while there are certainly benefits on cause-specific events, cardiovascular events, kidney events, you can see at the bottom there are even benefits on all-cause endpoints, ones that I think all of us are thinking about, like mortality in general, or keeping people out of the hospital for any reason, not for heart disease, not for kidney disease alone, but for any reason. So this is really a holistic medicine in that it addresses a core fundamental feature of aldosterone excess and mineralocorticoid receptor overactivation. We in this room are not unfamiliar with the mineralocorticoid receptor axis. In fact, MRAs like spironolactone and eplerenone have been in use for decades and are strongly recommended as class 1 recommendations in heart failure with reduced ejection fraction. And that's based on these 2 trials, RALS and Emphasis HF, and you could see just pretty remarkable reductions in clinical events, over 30% reduction in heart failure events and cardiovascular events in this population. The evidence base until fine arts heart failure was more uncertain. We had less robust evidence for MRAs. The only trial that has been tested an MRA in this population in a phase 3 level was the TopCat trial of spironolactone. And in this trial, it missed its primary endpoint in the overall population. Some post hoc analyses may have suggested potential benefits. And so fine arts was the first definitive trial of a beneficial effect in this population. There are certainly key differences between steroidal and non-steroidal MRAs, which I'll review with you. But first, I wanted to take you through what evidence we do have for spironolactone. I'd mentioned that the TopCat trial, which is a trial of 3,400 individuals across 6 countries globally, was actually an NIH-sponsored trial. And while it missed its primary endpoint, there was some signals towards potential benefit in those individuals who were randomized in the Americas. That's US, Canada, Argentina, and Brazil. And so this led to the potential signal that spironolactone may too have a role in HFpEF. There was a second trial of spironolactone in this exact same target population of heart failure with mildly reduced or preserved ejection fraction, called the SPIRIT-HF trial. This is the right side trial. This was just presented at the American College of Cardiology meeting in New Orleans, and so this is a bit hot off the press, and unfortunately, this trial too could not prove efficacy of spironolactone in heart failure with mildly reduced or preserved ejection fraction. So now we have 2 overall neutral trials. Both of them have important caveats. The TopCat trial had that regional heterogeneity. The SPIRIT-HF trial was stopped early because of loss of funding, so it was largely underpowered and had a large degree of drug discontinuation. But as of now, we don't have definitive evidence of spironolactone in HFpEF. Same is true for chronic kidney disease. There's only one well-powered trial of spironolactone in chronic kidney disease called the BARAC-D trial. This trial, too, unfortunately, did not meet its primary endpoint of reducing cardiovascular events. And as such, the only definitive evidence of an MRA being effective in cardio-kidney metabolism is with the non-steroidal MRA. There's one final trial, SPIRIT-HFpEF, which is the left-hand trial here. And in this trial, it's a larger trial, 2,400 patients, and that's ongoing. And so we'll hopefully see maybe a third shot on goal with spironolactone and HFpEF. Perhaps it might be effective. So I'm going to shift to some of the other pillars of care, because of course I'd mentioned that there are 5 approved therapies now for HFpEF. And so many of those are actually the SGLT2 inhibitors. In fact, 3 of the drugs that are approved for HFpEF today are in the SGLT2 inhibitor class. That's dapagliflozin, empagliflozin, and an SGLT1/2 inhibitor called sotagliflozin. So the evidence base for SGLT2 inhibitors is amongst the strongest for HFpEF because we have 2 definitive trials, Emperor Preserved and Deliver. Both showed entirely consistent results with 2 different drugs in the same therapeutic class. So I think we have great certainty that this drug is important and effective. And in fact, guidelines recommended it as the first foundational pillar of care. It's the first class 1 recommendation that we've ever had for any specific drug therapy in heart failure with preserved ejection fraction. And part of that strength of evidence comes from the adjacent conditions. SGLT2 inhibitors, of course, have been studied now in type 2 diabetes and chronic kidney disease, and in these adjacent conditions also have core roles. And so patients at the intersections of heart, kidney disease, and metabolic diseases also may benefit from the use of SGLT2 inhibitors. The use of GLP-1 receptor agonists has greatly grown in the US and worldwide, and we now understand that GLP-1 receptor agonists, or more broadly, incretin-based therapies, profoundly alter core pathophysiologies influencing human health. In heart failure with mildly reduced or preserved ejection fraction, we have nascent evidence. We have ongoing trials that are larger, but the initial evidence have come from small-scale trials, 500 to 750 patient trials. Interestingly, these trials have shown important signals towards benefit with both semaglutide and tirzepatide reducing clinical events in these smaller populations. You can see here, though, that the event rates here are lower and that there's relatively wide confidence limits, so will need to be substantiated with ongoing larger scale trials. And just like the SGLT2 inhibitors, the reason we are enthusiastic about this drug class is the benefit that we see on adjacent conditions. These drugs have, of course, been studied in obesity, type 2 diabetes, and chronic kidney disease, and have shown important benefits in those conditions. And so many patients, for instance, that we see with HFpEF today may have coexisting chronic kidney disease or obesity or type 2 diabetes, where we would also have an indication for the use of these therapies. So we're going to go to another test your knowledge question. Based on the results of the Fine Arts heart failure trial, what effect does concomitant SGLT2 inhibitor use have on the efficacy of a nonsteroidal MRA in patients with heart failure based on ejection fraction? So attenuation of efficacy in this population, no effect on efficacy, attenuation of efficacy in heart failure with reduced ejection fraction, no effect on efficacy in HFrEF, or no effect on efficacy across all heart failure phenotypes. Brilliant. Yeah, so a little bit of a tricky question, and we can see the spread of answers here. Fine Arts heart failure only studied patients with heart failure with mildly reduced or preserved ejection fraction. And the important point here is also that while we do believe nonsteroidal MRAs have a role in HFpEF, as of now, there's no evidence yet for heart failure with reduced ejection fraction with nonsteroidal MRAs. So we should continue to use spironolactone and eplerenone, which are strong foundational pillars of care in that population. And so Fine Arts enrolled about 13%, or about 800 patients, with concomitant SGLT2 inhibitors use in heart failure with mildly reduced or preserved ejection fraction, and there was no attenuation of benefit of the drug even in patients already treated on an SGLT2 inhibitor. So we're going to keep moving. I see a lot of questions around the comparative effects of a steroidal and non-steroidal MRA. And so I hope to address some of that in this next section, which is around the safety of a therapy. So what is the overall safety of a non-steroidal MRA? So this was the pivotal data from the Fine Arts HF trial. You can see that any serious adverse event, that is AE, was actually comparable between finerenone and placebo. However, of course, as with every MRA, there is higher risks of hyperkalemia, or elevated potassium levels, and in fact, hyperkalemia has been described in some cases as the Achilles heel of MR antagonism. So the safe inhibition of this core receptor, which we know is important for physiology and pathophysiology always comes at the expense of elevated potassium levels. So the degree at which we increase potassium might be where we can thread a safety needle. However, you can see that while it does increase risks of hyperkalemia, hyperkalemia of more significant consequence, like those leading to hospitalization or death, was rare and infrequent. And in fact, there were no deaths related to hyperkalemia in this large-scale program of 6,000 patients. And even across the 18,000 patients that have been studied in phase 3 trials with finerenone, there were no deaths related to hyperkalemia. So the potassium increases here on the absolute scale are actually relatively small. You could see average potassiums at the start of the trial was around 4.4 and increased to about 4.6. So there was about a 0.19 mean milliequivalent per liter increase in serum potassium levels. So on average, actually only a small increase. Of course, there are some patients where that small increase pushes them over to maybe a zone in which we might get more concerned. So biologically and chemically, what is the difference between a steroidal and non-steroidal MRA? Well, we use that terminology, steroidal and non-steroidal, because the actual backbone of the chemistry is distinct. You might recall from your medical student days that the steroidal, all steroids have 4 rings, and you can see that sort of stereotypical structure. Non-steroidal MRAs have a very, very distinct chemical structure, and in fact, the FDA, even because of the distinct chemical nature of these drugs, they don't consider them both in the same class. They're regulated entirely differently. Furthermore, steroidal MRAs like spironolactone are very potent drugs, but they're poorly selective. They're kind of dirty drugs that they affect a number of receptors like estrogen, progesterone, sex-based effects. But they also have longer acting potential. They stay in the system for over 24 hours in terms of a half-life. They have multiple metabolites, so it makes it less clean of an inhibition of this core receptor. Non-steroidal MRAs have a short half-life, only about 2 to 3 hours, have no metabolites, and are highly, highly potent selective for the MR receptor, so there's no off-target effects on gynecomastia or sexual dysfunction. So many of the questions, we actually have 3 questions related to, is there head-to-head evidence of spironolactone against finerenone? Many of us are asking perhaps the most important question of, can I just use the cheaper alternative of spironolactone? We are comfortable with this drug, we've used this drug, it's a household name, why can't we use it? Well, while there isn't head-to-head outcome evidence, and I only could make those indirect comparisons, that finerenone has been established in 3 large-scale trials of chronic kidney disease and HFpEF, all of which were positive, and spironolactone has been now studied in 3 trials of TopCat, SPIRIT-HF, and BARAC-D in those same populations of HFpEF and chronic kidney disease, and weren't successful, or at least didn't meet their primary endpoints. While those are indirect comparisons, there have been direct evidence of safety comparisons. So this, for instance, was the ARTS trial. This was a phase 2 trial in which finerenone was directly compared against spironolactone. And while this isn't an outcomes trial of looking at clinical events and mortality, you can see here that spironolactone increased risks of hyperkalemia, renal impairment, kidney failure to a greater degree than finerenone. And so this was actually validated in a much more recent trial, actually, that was just conducted in the last few months in primary aldosteronism, which we use MRAs, of course, for, and the same safety profile was demonstrated, in which spironolactone leads to greater degrees of potassium increases compared with finerenone. So what about our other classes of therapies in this population? I'll move through this relatively quickly because many of you might be familiar with SGLT2 inhibitors and GLP-1 receptor agonists because of their more long-standing use. SGLT2 inhibitors, the primary safety issue that's most frequently encountered is genital mycotic infections. These are yeast infections, not urinary tract infections. In fact, severe UTIs weren't significantly increased in large-scale pivotal trials of SGLT2 inhibitors. There are some very infrequent adverse events that are mentioned in clinical practice guidelines as well as in FDA labeling. These have been observed in select trials. And then adverse events in blue here that we should be aware of. For instance, diabetic ketoacidosis only occurs in people with type 2 diabetes, and so with diabetes, not in the large number of patients we treat now with SGLT2 inhibitors without diabetes, and is often in periods of prolonged NPO status or fasting. Hypoglycemia is very, very infrequent with this class of therapies because tubular excretion of glucose shuts off in states in which there are low plasma levels of glucose. And volume depletion as well is infrequent and can be largely managed by adjustment of diuretics, for instance, like thiazide and loop diuretics. GLP-1 receptor agonists, the most common side effect profiles, of course, related to the GI system, nausea, vomiting, but also lower GI symptoms are present, including constipation. This can be managed expectantly and managed with conservative management, including dietary changes. Other adverse events are very, very infrequent with this class of therapies. So we're going to move to the next polling question. It's a 58-year-old man with HFpEF and chronic kidney disease who develops gynecomastia 3 months after starting a steroidal MRA. That's like spironolactone or eplerenone for blood pressure control. Why would switching to a non-steroidal MRA, like finerenone, reduce the risk for this side effect? And I'll let you read the answer choices here. Superb. So the majority said the correct answer, which is high MR binding selectively. And selective inhibition of the MR is the critical point here. Spironolactone is actually a very, very potent drug. We know this in, for instance, resistant hypertension management. In the Pathway 2 trial, for instance, there was robust blood pressure lowering, even as an add-on therapy. The issue is that the safety effects occur with its prolonged effects as well as its off-target effects beyond what we're trying to inhibit, which is that MR receptor. All right, so why don't we pause and address a few questions, because there are a lot of terrific questions that have come in. And one question is interesting, and I'm curious, Dr. Riza, your thoughts as well. One question is related to if you have a patient who's stable with heart failure with preserved ejection fraction on a steroidal MRA, like spironolactone, would you switch them to a non-steroidal MRA? And while we don't have direct evidence to guide this specific question, my general sense is if a patient is doing well on a current therapy for a therapeutic approach that we think is reasonable and is safely being managed with that medication, I generally wouldn't alter their care. That said, if the patient, for instance, has other indications beyond HFpEF, for instance, diabetic kidney disease as well, there I think you have more compelling evidence that we should be treating more than one condition. The issue of stability, though, is something that we encounter frequently in heart failure. Often we say that if someone's in ambulatory care in our office and walks into our offices, then we say, okay, they're probably stable. But then we look at their profiles, and often there is uncontrolled risk there. For instance, they may have albuminuria levels, UACR levels that are markedly elevated. That provides additional rationale that we should be using focused, targeted, evidence-based risk-lowering therapies.
Yeah, I totally agree. This is something that we're talking a lot about within the field of cardiology, this concept of residual risk and how to quantify that. What does that really mean? And despite all of these amazing advancements that we've just showed you in medical therapy, we still have many patients being hospitalized with heart failure, decompensations, many patients progressing to death still in the contemporary age with these fantastic foundational therapies. So this tells us that we are missing this residual risk. There are still axes that we're not treating. And likely these things are, like Dr. Vaduganathan said, this persistent albuminuria, persistent hyperglycemia, natriuretic peptides that still remain elevated, signs that the underlying pathophysiology is still progressive. And that's why we're trying to change at least how we think about it in our field, that no heart failure patient is truly ever stable. We shouldn't think about them that way. They're still on a chronic course of progression. And we should be doing everything in our power to institute the therapies that we know arrest that progression, if we can, reverse that progression in some way. And so I completely agree, I think, with your realistic, very clinical approach to that concept of the patient. But still, in my mind, the question I ask myself with every patient I see in clinic is, am I doing everything I can to reduce the risk for this patient?
Fantastic. There are a couple of quick questions related to the edges of evidence. Those individuals with, for instance, pulmonary hypertension, and the question was, do we have any evidence of MRAs in the treatment of pulmonary hypertension distinct from HFpEF? And the answer to my knowledge is no. None of these therapies have been studied specifically for PH, but this is a topic that's increasingly becoming important, especially the overlap between HFpEF and pulmonary hypertension. The second question was related to individuals who have really substantial elevations in blood pressure, sort of severe ranges of hypertension, including resistant hypertension. And I failed to mention that we do have a very clear indication for spironolactone for the management of resistant hypertension. And in those patients, I do believe that steroidal MRAs actually have more potent blood pressure lowering effects. And so I do commonly and frequently use spironolactone for that purpose of especially patients with early LV remodeling like left ventricular hypertrophy. So I don't, and finerenone hasn't been studied specifically in like primary aldosteronism or resistant hypertension to the same extent as spironolactone. So why don't we keep going? We're going to move more into now the clinical and therapeutic implications for this shifting landscape of evidence.
Okay, we've told you a lot about the foundational evidence for these therapies now, so let's take this to the bedside and talk about how we would approach these therapies with the patients in front of us every day. So what clinical and patient-related factors should really inform our treatment strategies here? So let's review. As we've talked about these 4 pillars, these foundational pillars now of treatment. We're targeting, again, strong evidence in chronic kidney disease, type 2 diabetes, heart failure with preserved ejection fraction, and mildly reduced ejection fraction here with the RAS inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and nonsteroidal MRAs. Again, we've talked about how they provide synergistic benefits when combined with traditional management strategies, and synergistic benefits combined together with each other. So these are data largely from Dr. Vaduganathan himself here as well, showing you the outcomes of combination therapy across CKM conditions, again, modeling outcomes like cardiovascular death. And you can see here, based on the population, heart failure mildly reduced and preserved EF, CKD, and type 2 diabetes. Combination therapy, the lines that you see on the bottom of these plots, SGLT2 inhibitors plus GLP-1 receptor agonists plus MRAs or nonsteroidal MRAs, give you the most favorable outcomes. So again, this is the treatment strategy, a combination approach that we should be pursuing for these patients with these clusters of comorbidities and diseases. And here again is the lifetime benefit of adding a nonsteroidal MRA to, again, our foundational therapy up until this point of SGLT2 inhibitors, again, our class 1 recommended therapy for heart failure with preserved EF. And you can see that combined with SGLT2 inhibitors and nonsteroidal MRAs reduces the risk of cardiovascular death or first worsening heart failure event by over 30%. So again, this is again revisiting that concept of how do we reduce residual risk? Well, just in the last couple of years, this is a citation from Dr. Vaduganathan himself, published earlier this year. We are getting some answers to these questions. So let's put this into practice. Hopefully you'll recognize some of the patients that you see every day in the case examples that we have here for you. So this is Miss Marjorie. She's 67 years old. She has CKD, diagnosed 8 years ago, type 2 diabetes and HFpEF. She has a family history of hypertension. She was recently admitted to the hospital for heart failure. Her current therapy is, as you see here, a RAS inhibitor, beta blocker, statin, and SGLT2 inhibitor. So not bad. Her ejection fraction is 63%. Blood pressure is elevated, 130/80. Urine albumin creatinine ratio, UACR, is significantly elevated, 300 milligrams per gram. EGFR 45. She's obese with a BMI of 30 and an A1C of 7.2. So Dr. Vaduganathan, how do you conceptualize this patient with her comorbidities, her conditions, her residual risk, as you can see here, perhaps indicated as we were talking about with her laboratory data, and then her foundational treatment?
Yeah, so I hope this resonates in this room of a common patient that all of us see. And this is often a person who is cycling between the hospital, outpatient clinic, between specialists, generalists, and here you could see many, many residual targets in which we can actually potentially influence the trajectory of her disease, including a UACR level of 300. So this is now in this kind of borderline macroalbuminuric or A3 range. Her EGFR is 45, her BMI is 30. And in terms of medical therapy, she is on some of the therapies that we think about, including a renin-angiotensin system inhibitor and an SGLT2 inhibitor. But she's also on, for instance, a beta blocker. And a beta blocker in current guidelines has actually fallen out of favor of HFpEF guidelines. Beta blockers are no longer recommended. And in fact, it is one of the targets of quality improvement that I actually try to discontinue if there's no other indication for use. Most commonly would be atrial fibrillation or some degree of other arrhythmia burden or anginal-based symptoms. But for blood pressure lowering alone, I often will reach for some of the other therapies we're discussing because those therapies also have been shown to reduce risk and are recommended in guidelines.
All right. So what is our next best treatment option? Should we increase the dose of the SGLT2 inhibitor, add a nonsteroidal MRA, switch the ARB to an ARNI, sacubitril valsartan, add a GLP-1 receptor agonist, or make no changes to the heart failure regimen? Give everybody a few seconds to think about this one. All right, Dr. Vaduganathan, what do you think the answer is?
Yeah, this was intentionally intended to be complex. There's sometimes in clinical care, as we know, there are often more than one right answer, and that there's often more than one decision that can be made on a given day. And so in this case, I think that the major unmet needs here are related to the kidney. It's really sort of puts this person in a KDIGO range of KDIGO classification in terms of kidney disease progression at high or very high risk. And so I would focus on therapies that are strongly recommended in clinical care guidelines for kidney disease, including adding a nonsteroidal MRA. I think that adding a GLP-1 receptor agonist is very, very reasonable in this individual. Not only would it address some of the metabolic risks like the BMI of 30 or an A1C of 7.2, but also we know GLP-1 receptor agonists in the FLOW trial, namely semaglutide, did reduce kidney disease progression and lowered albuminuria levels. And so I think it's either likely this is a case in which I'll try to peel off the beta blocker, add a nonsteroidal MRA, and add a GLP-1 receptor agonist, but potentially that might occur over sequential visits.
There we go. Okay, we'll just go back and show you. So that's exactly how we mapped out the case here. So albuminuria seems to be the most severely undertreated target here. So agree, our approach would be add a nonsteroidal MRA, in succession likely add a GLP-1 receptor agonist as well. All right, so now we have a new case. This is Miss Michelle. She's 54 years old, and now you're seeing her in the emergency department. She has progressive dyspnea for 3 months. She has no known prior history of cardiovascular disease or other chronic conditions. She does not smoke or drink alcohol, and she tells you she's been short of breath with minimal activity for the last couple of weeks. She's had no previous exertional symptoms. On exam, her blood pressure is elevated, 146/82. Her heart rate is 78. She has Rales bilaterally and 1+ bilateral peripheral edema. Of course, you're in the emergency department. You have quick access to at least an electrocardiogram, so we're showing you that there. And then a few hours go by and you're harassing the cardiology fellow to come in from home. That was me, that was both of us at some point. And so we come in and we do the echo, and you see that she's got an ejection fraction of 56%, mild concentric left ventricular hypertrophy. Left atrium is mildly enlarged. She has mild mitral regurgitation, mild tricuspid regurgitation, and an estimated pulmonary artery systolic pressure of 35. Her other labs are back by this time. Hemoglobin's 14.2, NT-proBNP is elevated 1500. Her creatinine's 1.8 with a GFR of 42. Another UACR that's significantly elevated, 400, and a serum potassium of 4.8. So, Dr. Vaduganathan, how do we conceptualize what's been going on with Miss Michelle recently?
So unfortunately, this is the typical presentation for newly diagnosed heart failure with preserved ejection fraction. And when we look at epidemiology, we know that over half of cases of heart failure still today are diagnosed first in the hospital when people actually admitted with acute heart failure. And while we do have better screening, like with natriuretic peptides like NT-proBNP and BNP, the use of NT-proBNP and BNP in the outpatient setting is relatively infrequent, and we sometimes write off some of the subtle early evidence of congestion and volume excess to other systemic issues, for instance, aging or adiposity or obesity. So this is a very classic presentation in which there is clearly peripheral evidence of volume excess with lower extremity edema. The echocardiogram has all the typical features, and you could see here nothing is striking. There's no overt left ventricular dysfunction that you can put a pin on. But here you have concentric LVH, left atrial enlargement, and the left atrium is really the barometer of the heart. It's the barometer of the pressure that is sensed downstream of that ventricular diastolic stress. And then you see subtle evidence of an elevated pulmonary artery systolic pressure that's estimated. You also see that NT-proBNP here for scaling purposes, and one of the questions is actually really good about what is an abnormal NT-proBNP. We say that for initial diagnosis, an NT-proBNP above 125 picograms per milliliter, and that's the universal threshold now for diagnosis. And so you can see here, this is markedly elevated, and so well within diagnostic criteria. So she has signs, symptoms, an echocardiogram with some subtle myocardial dysfunction and abnormality, and markedly elevated filling pressures based on biomarkers.
All right, so what should we do? First, we'll diurese her, but then what's the next step? Should we start an ARB for BP control? As you can see again, her blood pressure is elevated. Should we start an SGLT2 inhibitor first, then an MRA later, or an MRA first and an SGLT2 inhibitor later, or should we start an SGLT2 inhibitor and an MRA together? Give you a couple minutes to think about this one, or seconds, I should say. All right, what are we ordering?
So I think that, again, we have a few different options here. In this case, I think this person has clearly manifest as someone who is going to be high risk. They've already presented at the hospital in acute heart failure, markedly congested. And in this particular circumstance, I use all available tools to best combat disease progression. The hospitalization is a unique time point in care in which we have a captured audience of patients. We're able to actually influence their care, just like we do after myocardial infarction. After acute heart failure presentations, we really should be optimizing their medical therapy with multiple drug therapies. And so I would start an SGLT2 inhibitor and an MRA at the same time in this patient. It's a little different from a patient who we may be meeting in the outpatient setting, where we might have more time and we can layer and sequence therapies over a longer term horizon. And there's actually a very good question before we keep going here about what happened to the good old physical exam of looking at clinical signs for heart failure, like an elevated JVP. And that's absolutely right. Still today, the guidelines strongly endorse the foundations to early detection of heart failure is still reliant on a good physical exam. That's of course going to be now bolstered with some of our point of care ultrasound technologies, as well as our biomarkers, but this is only additive on top of foundational exam skills.
All right, let's put it all together with our next knowledge check. So now it's your patient with HFpEF, CKD, and type 2 diabetes, an A1C of 7.9%, and BMI of 36, UACR of 24, starkly different from our last two cases, eGFR of 60. Current medications include a maximally tolerated ARB and SGLT2 inhibitor. So what's the most appropriate next step to reduce residual cardiovascular risk? This one is one you can answer with your QR code. Intentionally a little bit tricky, and I hope you've been getting throughout our time together. Some of these don't have one exact right answer that you have to do, but I think we're catching on to the general concepts, right? And so this is actually, a third of you said what we would say, add a GLP-1 receptor agonist. And again, thinking back to how we've been framing these cases of figuring out what's the most sort of uncontrolled cardiometabolic risk factor here, we thought that with her BMI of 36, opportunity for weight loss therapy would take precedent here to, again, reduce that risk, that pathophysiology cascade coming from that excess adiposity. So we'd start with the GLP-1 receptor agonist, and then recheck biomarkers. We'll keep an eye on that UACR, keep an eye on that renal function, keep an eye on that A1C, and then subsequently see if it's time to add a nonsteroidal MRA or augment blood pressure control. All right, so now to our last section. We'll talk about keeping patients on track and us on track. How do we monitor and manage patients receiving nonsteroidal MRAs? So I don't know about you, but in the last 5 years when all of these therapies were coming sort of in full force, it takes a lot to learn how to prescribe them, right? They all have different doses. Some you inject, some you take by mouth. I mean, like, there's so much to keep up with. So how do we figure out and how do we really contextualize these different dosing paradigms? So we're going to start specifically on the newest therapy, the nonsteroidal MRAs. So what factors should inform your long-term management, and how do we really start using these medications? So here are major clinical considerations for when you start nonsteroidal MRAs and how you actually practically do this in your outpatient or inpatient setting. So we'd want to, just like you're probably used to all other heart failure and cardio-kidney-metabolic therapies, get a BMP, measure your serum potassium and eGFR before initiation of these therapies. And then let's start with a patient who has normal renal function, eGFR of greater than 660 or above, as you can see on the bottom. Your recommended starting dose for your nonsteroidal MRA is 20 milligrams daily, and your target dose is 40. We'll talk about titration on the next slide. If you have mildly reduced kidney function, some evidence of chronic kidney disease, your eGFR is between 25 and 60, your starting dose is 10 milligrams daily, your target dose is 20. And if your eGFR is less than 25, again, you have advanced CKD, we do not have a recommendation to start therapy in that population. All right, so you've started therapy, and now how do we get to target dose? Well, again, after you start therapy, you remeasure serum potassium and eGFR after 4 weeks, and then we'll walk you through the slide as you see here. So you have your current dose there on the left. Now, if you're on 40 milligrams and you're able to achieve that, you just maintain. Obviously, if your potassium is within the range there, as you can see, with potassium less than 5, you can either, again, maintain the highest dose, or that's when you can up titrate from your 20 to 40 or from your 10 to 20. If you have a little bit of increase in your potassium, again here, the key is this purple box. Your potassium is 5 to 5.5, stay the course. Maintain the current dose. Your risk of adverse events at this level is very low. It is not worth risking the benefits you're getting from the nonsteroidal MRA. So again, you get a potassium back, it's in that range, hold steady at your current dose. If your potassium is slightly more elevated in that 5.5 to 6 range, then you can de-escalate the dose as you see there. Again, if you have significant hyperkalemia, K in excess of 6, you withhold and could restart at 10 milligrams when the potassium is dropped to less than 5.5. And then how do we manage hyperkalemia with nonsteroidal MRAs? Very similar to what everybody is likely used to with the steroidal MRAs. Number one, of course, address the correctable factors. Make sure the non-RAS inhibitor medications like NSAIDs are not being taken. Address dietary potassium intake and consider appropriate modification. Remember appropriate use of diuretics, other things that manage the potassium like serum bicarbonate or K-exchange agents, and remember your concomitant SGLT2 inhibitors also help mitigate, reduce that risk of hyperkalemia. And of course, your last resort should be reducing the dose or discontinuing the RAS inhibitor or the MRA. Again, because of all the benefits that we've outlined with you this evening, this really, again, should be your last resort. Now, this slide was given to us, the role of primary care in managing patients with heart failure with mildly reduced or preserved ejection fraction. I don't think as cardiologists we should be telling you what the primary role of primary care is. You should be telling us how we can help you. So this is what we came up with. And again, you can see it's really all of us working together. Primary care, of course, integral in the diagnosis and initiation of GDMT, guideline-directed medical therapy, comorbidity management, of course, referral to cardiologists for aspects that you may see here, and some we'll continue to discuss in the Q&A, confirmation of the diagnosis, optimization of guideline-directed medical therapy, perhaps guiding us through some of these challenging drug titrations, of course, enrolling in clinical trials, so important, and then referral to somebody like me, an advanced heart failure specialist, if we need advanced diagnostic testing, management of special or unusual cases, for example, mimickers, as we say, of HFpEF, things like cardiac amyloidosis, hypertrophic cardiomyopathy. Definitely, you're suspicious, send it over to us. We'll work through it. And then consideration for advanced therapies, that's what we're talking about when we talk about LVAD or transplant, again, mostly in the heart failure with reduced ejection fraction spectrum. And of course, all our multidisciplinary colleagues helping us manage all the comorbid conditions we see here. So our final knowledge check, I believe, you're a patient with CKD, type 2 diabetes, HFpEF, stable eGFR, on a RAS inhibitor, SGLT2 inhibitor, nonsteroidal, finerenone 20 milligrams for the last 6 months. The latest labs show a serum potassium of 5.4. No other lab abnormalities. How should you proceed? All right, I was worried I didn't see a lot of phones go up, but I think that meant you all just had it in your head and you knew the answer at that point. You didn't even feel like you needed to pull the phone out and vote. So, and for those of you who voted, very well done. K is between 5 to 5.5. We're going to stay the course, make no changes.
I mean, if there's a single thing to take away from this hour-long session is to not panic in a range of potassium between 5 and 5.5. We've learned so much with mineralocorticoid receptor antagonists. And in fact, there was a trial in the New England Journal of Medicine just in the last year called the podcast trial that actually looked at what if we actually physiologically increase potassium with potassium supplementation and MRAs in people at high risk for ventricular arrhythmias. And in fact, not only could you safely do that, but you lower the risks of cardiovascular events if you do so. So this range, I think, is something that we've traditionally raised red flags, stopped therapies. This is important to continue. Dr. Riza, there's a question related to how to manage patients with postural hypotension. And I'm curious if you have any tips or tricks in your heart failure bag in terms of continuing guideline-directed medical therapies, even in individuals with postural hypertension.
Yeah, it's a very good question, a very challenging situation. So I think the first thing that I would do is make sure that that's the diagnosis. There are many conditions, cardiovascular and multisystem, that can cause autonomic dysfunction. I mentioned one of them earlier, cardiac amyloidosis, for an example. Systemic amyloidosis can infiltrate the autonomic nervous system, cause autonomic neuropathy. There are other conditions, even hypertrophic cardiomyopathy has autonomic function dysregulation and can cause these sorts of symptoms. So I would say, first thing I always do is take a step back and make sure that the diagnosis is correct, make sure that there's nothing else actually causing that autonomic dysfunction, because again, that would likely even change the paradigm for therapy that I'm considering. So let's say, for hypothetical of this example's sake, that we've done our due diligence, there's nothing else, it is just sort of an unexplained idiopathic postural hypotension syndrome. There, of course, I think the first line of therapies are things that are like supportive care, non-medication therapy, so that's things like increasing salt, fluid intake, electrolyte intake, abdominal binders, compression stockings, physical therapy, rehab, these sorts of structured exercise programs, sort of the non-pharmacological interventions that can sometimes help. There have been some other things obviously studied in these populations, that very heterogeneous populations, so again, it's hard to pinpoint exact populations, but things like fludrocortisone, ivabradine, which is a funny channel blocker medication, typically used to reduce the heart rate. It has other indications in cardiovascular disease, but has been studied in POTS, for example. In some populations, it's shown benefit. So there's sort of that concept of other pharmacological therapies that can, again, help support the blood pressure to facilitate. And then, being realistically, sometimes we can't, to our best efforts, really use some of these therapies, because again, I always talk with my patients with heart failure, my goal is to improve your quantity of life and your quality of life. And so if I'm doing something to you that is reducing your quality of life, that is something I don't want to do. So we have that sort of shared decision-making discussion and talk about risk benefits.
That's a great pearl in terms of excessive postural hypotension and autonomic dysfunction should start to trigger, perhaps there's other etiologies of HFpEF. And same is true, another question, it's actually a really great question. What if you encounter a markedly elevated NT-proBNP level, let's say above 5,000 or 10,000? Those patients I actually also consider strongly for primary myocardial diseases like cardiac amyloidosis. And so If something is far off the spectrum of what you traditionally are considering or used to evaluating, that might be a reason that there may be something else going on as well. A couple of questions related to non-diabetic forms of chronic kidney disease. Hot off the press, just in the last few weeks, finerenone was studied in a non-diabetic kidney disease trial called FIND-CKD. This is being presented at an upcoming kidney disease meeting at the ERA Congress. So we'll learn more, but at present, its primary indication is in type 2 diabetes with concomitant chronic kidney disease. There's another question on non-diabetic kidney disease with SGLT2 inhibitors. And SGLT2 inhibitors have been well studied in both diabetic and non-diabetic forms of chronic kidney disease, namely in the EMPA-Kidney trial and the DAPA-CKD trial. Both of these trials had large subsets of patients without diabetes and showed clear benefits in reducing kidney disease progression. There's an additional question about what if those patients have low levels of albuminuria. So now we're dealing with not only non-diabetic kidney disease, but low levels of albuminuria or non-albumuric kidney disease. So EMPA-Kidney did study even those patients, and in that cohort of individuals, there was some slowing in kidney disease progression, but it's of smaller magnitude. These are relatively lower risk patients in terms of kidney disease progression. They are unlikely to experience dialysis or sort of serious long-term events related to the kidney, but SGLT2 inhibitors can actually modify cardiovascular risk even in that group of patients. So I think that's all the time we have. We have a couple of questions about other therapies. We're happy to kind of help answer them. For instance, how do you stop a beta blocker? Generally, if they're low or moderate doses, you can stop the therapy and you generally won't have untoward hemodynamic consequences. If patients are on very high doses of beta blockers, for instance, metoprolol succinate doses above 100 or 200 milligrams, then cutting the dose in half first before stopping it is probably reasonable. Direct renin inhibition, the only common therapy was aliskiren, was studied in cardio-kidney disease, but unfortunately, when layered on top of other RAS inhibitors, it had more safety issues and no substantial clinical benefits. So that drug program was largely discontinued.
Believe it or not, we made it through all of the questions in that rapid fire segment. So thank you for all of your engagement throughout the session. It was really fun for us up here to be able to engage with you in this way. Thank you again for joining us tonight. You can see here from the slide, you can download the slides from today's event and watch for the multimedia version of this symposium to be available in the coming weeks. So thanks again for joining us and have a great ACP.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.